Hello everyone. Today we'll be talking about warfarin-induced coagulopathy. So during our clinical practice, many a time we come across patients who are on warfarin for some reasons, like an atrial fibrillation or patient with mechanical valves. They'll be on warfarin for preventing anticoagulation. But sometimes due to the warfarin, there may be a overdose of it, or a patient may develop coagulopathy. So normally what happens is warfarin is nothing but it's a vitamin K antagonist. So generally vitamin K is responsible for generation of four clotting factors. So these are the clotting factors which are responsible for the blood to be clot in the vessels or in the arteries and veins. So what are the vitamin K dependent clotting factors are prothrombin, that is factor 2, factor 7, factor 9 and factor 10. So vitamin K antagonist, that is warfarin, it's an inhibitor of these factors. And if the warfarin inhibits these factors, what will happen is that there will be decrease in clotting and there will be high chances of bleeding or blood may become more thinner. So these are the coagulation cascade. As you can see, this is intrinsic pathway and this is extrinsic pathway. So factor 2, 7, 9, and 10. So that is both extrinsic and intrinsic pathways are get affected by use of warfarin. So whenever there is overdose of it or there is coagulopathy, these are the four options available to counteract the warfarin effects. That is vitamin K. Since warfarin is a vitamin K antagonist, if you give vitamin K, it will be an opponent to this warfarin and will help in generation of factors 2, 7, 9, and 10 and automatically will reverse the warfarin effect. Fresh frozen plasma is generally generated from the whole blood. Whenever a patient donates, whenever any person donates a blood, so this blood is separated into two things. So the whole blood is converted whenever it is underwent centrifugation, it gets separated into packed red blood cells and platelet-rich plasma. So red blood cells are separated and platelet-rich plasma is separated. When this is centrifuged, platelets and plasma get separated. So when platelets and red blood cells are removed from this whole blood, the only thing remaining is the fresh plasma. So this is fresh plasma on freezing becomes fresh frozen plasma. That is, it basically contains what is called as all the clotting factors and some amounts of leukocytes. It is if on further thawing or centrifugation, it gets separated into frozen plasma and cryoprecipitate. So cryoprecipitate is the one which mainly contains the factor 2 and 10, and it does not 2 and 10 and 2 and 8. It does not contain the other factors. So let's come to our main topic, that is warfarin. So since cryoprecipitate does not contain sufficient levels of vitamin K depending factors, that is, it does not contain the factor 7 and the factor 9. So thus it is not an option for vitamin K antagonist reversal. So coming to the topic warfarin over anticoagulation. So suppose patient is on warfarin, and whenever the patient is on warfarin, we monitor with prothrombin time and INR. So suppose the patient is having an INR of less than 4.5 and there is no bleeding or need for rapid reversal and patient is on warfarin. So usually suppose the patient is on case of atrial fibrillation, the target INR is between 2 to 3. Suppose the INR is more than 3, that is it's around 3.5 or 4 or whatever is less than 4.5. So if there is no active bleeding, you need not be any worried. You can just lower the dose according to the recommendation, or maybe you can stop a tablet for 1 day and then decrease the dose. So suppose the patient is on warfarin 6 mg or 7 mg, you can stop the tablet for 1 day and then maybe from the next day you can start at a lower dose. So suppose patient was on 6 mg, you can make it 5 mg and then keep monitoring the INR till the patient achieves the target INR. So suppose the INR is between 4.5 to 10, but there is no active bleeding. So you need not worry, you do not need any blood transfusion or anything. You can just omit 1 or 2 doses. So suppose you stopped the drug warfarin for 2 doses, then you try to recheck monitor INR and just readjust the dose. You can decrease the dose of that and readjust the dose. That will be sufficient. So 2012 guidelines suggest against routine use of vitamin K. So suppose there is no bleeding and if the INR is between 4.5 to 10, you need not routinely administer vitamin K. On stopping of drug itself for 1 or 2 doses, the INR will get normalized. And INR should be reduced uh, within 24 hours. So few guidelines recommend that you can give vitamin K in this group of patients. That is, the dose is 1 mg if you're giving orally, or 0.5 mg if you're giving intravenously. So suppose the patient INR is more than 10, but there is no bleeding. Actively, there is no bleeding in the patient. So what you have to do is you stop warfarin, you keep monitoring INR and readjust the dose accordingly. Next, you can do is the guidelines recommend that in this patient that is INR of more than 10, you should definitely start them on vitamin K. Vitamin K. The dose is not decided. So generally, what the dose is that you can give either 2 to 2.5 mg oral, or 0.5 to 1 mg IV in this group of patients. So 2.5 mg oral or 0.5 to 1 mg IV. So suppose patient is any elevated INR, that is any patient who has INR of more than any elevation, but there is only minor bleeding, then you need not worry much. You just have to stop the warfarin, monitor INR and readjust the dose. You can consider for vitamin K, if you are giving orally, you can give 2.5 to 5 mg orally, or you can give 0.5 to 1 mg if you are giving intravenously. Generally, vitamin K effect will take time, around 6 to 12 hours, and after that, the effect of vitamin K will start. So, however, you have to generally check the vitamin INR levels after 12 to 24 hours of vitamin K administration to check that. And if the INR is not within the normal range, then you may have to repeat the dose after 12 to 24 hours. So suppose the patient is having a major bleeding or any elevated INR, first you have to do is, the patient is having a major bleeding, you have to stop the warfarin. We just monitor INR and readjust the dose. So in this patient, since the patient is having a major bleeding, you cannot wait till you administer vitamin K, because the vitamin K usually takes time, because after administration vitamin K, the new clotting factors has to form, which may take around 6 to 12 hours. So you have to generally wait. You have to give vitamin K, but to immediately reverse the action, you have to administer it on patient on prothrombin complex concentrate, or you can give fresh frozen plasma or recombinant factor 7A. So remember, one thing is important in this: in case of major bleeding, the dose of vitamin K should be IV 5 to 10 mg, and whenever you are giving IV, you should not give it direct IV. You should dilute it in 50 ml of fluid and administer it slowly, because there are the risk of anaphylaxis present with that. So suppose the patient is having life-threatening bleeding and elevated INR, you have to hold warfarin therapy and give a fresh frozen plasma with vitamin K 10 mg by slow IV infusion. So management options in patient. uh, So suppose a patient is on warfarin and he develops the intracranial hemorrhage. So how do you manage this case? So suppose the patient is on vitamin K. So first thing, the option is to give vitamin K to this patient immediately. That is, you have to give either oral. Traditionally, we used to say that you should give 2.5 to 5 mg oral, or IV of 0.5 to 5 mg. Now, modern guideline has now been evolved. Now, the guideline says that the vitamin K dose in patient with major bleeding or intracranial hemorrhage should be 10 milligrams intravenously of vitamin K. And always remember that there are risk of 3 per 1 lakh risk of anaphylaxis. So it should be always be infused very slowly. So vitamin K therapy alone will require 12 to 24 hours. Reversal begins within 6 hours. So generally it takes 12 to 24 hours time for action to reverse warfarin coagulopathy, and thus it is not recommended for immediate reversible as in case of intracranial hemorrhage. So you have to give this drug, but along with that you should make sure that you give other therapies to rapidly reverse the warfarin-induced coagulopathy. Next therapy which you can do is that is also remember that if the INR is not normalized within 24 hours, you have to repeat INR and may have to give a second dose of vitamin K. Second option is the plasma therapy. So plasma therapy is nothing but, as we have already discussed, that after giving when ablation, any person donates a whole blood, so it is centrifuged into packed cells and platelet-rich plasma. And when this plasma is separated again, platelet is separated again, and the fresh plasma is there. This contains all the clotting factors. So since vitamin K antagonist is against the clotting factors, you have to give clotting factors in this patient. But the only problem is that since it is a plasma, it contains a large amount of volume, and for to reverse that, may have to give a large amount of blood or a fresh frozen plasma, which may lead the patient into volume overload status. So you have to make sure that patient is not too much volume overloaded, and you may have to give a diuretic therapy in between. So dose of plasma therapy is that minimum of 15 ml per kg or 30 ml per kg has to be given, or you have to give 4 to 8 units in an adult patient. Okay, so this 15 to 30 ml per kg is the normal dose of fresh frozen plasma. Next, most important thing is prothrombin complex concentrate. So this is previously there are few contains prothrombin complex concentrates three factors, that contains factor 2, factor 9 and factor 10. It generally does not contains factor 7. So this is not useful in patients with warfarin induced coagulopathy. In warfarin induced coagulopathy, the main thing is that it should contain the factor 7, and that's why 4 factor prothrombin complex concentrates are generally used. What is the recommended dose is that suppose the patient is INR is within therapeutic range and has developed ICH, then the dose should be 25 international units per kg. Or suppose INR is in exceeds the therapeutic range, then you have to give the dose at 35 to 50 international units per kg. The safety of prothrombin complex concentrates in the setting of emergency reversal of warfarin and aggression remains a subject of debate. So what is the problem with the prothrombin complex concentrates is that there is high chances of, because it contains a clotting factor, there is high chances of thrombogenicity. So this, when after administering the plasma concentrate, patient can develop thrombus, but when patient is having intracranial hemorrhage, the risk of thrombosis is much less. However, the benefit can be much more. So that's why, so irrespective of the risk of thrombosis, you have to give the 4-factor prothrombin complex concentrate. However, note that it has been recommended that few studies says that whenever possible, patient who are receiving this prothrombin complex concentrate should be under low dose heparin prophylaxis. But in the case of active intracranial hemorrhage, it may not be possible to give heparin. But so here in this case, the benefit of prothrombin complex concentrates is much more when compared to the risk of thrombosis. So it has to be administered in this case. Another limitation of prothrombin complex concentrate is that it has a potential risk of transmitting infectious agents. Even though use various processing methods as nanofiltration or vapor heating, we can use that. However, there has been reported cases of parvovirus B-like seroconversion have been reported in recipients of prothrombin complex concentrates. So when you compare fresh frozen plasma or 4-factor prothrombin complex concentrates, the fresh frozen plasma takes longer time to administer because it's a large in volume. You have to be very much careful because the large amount of volume has to be given to the patient. It can transmit very large amount of diseases, and there is a risk of transfusion related acute lung injury. The when Similarly, when we take 4-factor prothrombin complex concentrate, the limitation is that their availability is limited, and some preparation, that is the 3-factor plasma prothrombin complex concentrate, lacks factor 7, and it requires almost a donors of around 3,000 to 20,000 donors as required to generate this in sufficient amounts, and it can transmit some diseases, and the main limitation is its thrombogenicity. Now is recombinant factor 8(7)A. This is a new one. It is still off-label, and the dosage recommendations are currently unresolved. So generally, the dose they say is the fixed while dosing of 2 mg will provide you 20 to 40 grams per kg for patients between 100 kg and 50 kg of body weight. So clinical benefit in these settings have not been established, and there is a high risk that this recombinant factor 8A can develop arterial thrombotic complications. So on summarizing, so suppose any patient has developed, warfarin patient has developed bleeding or intracranial hemorrhage, you have to give vitamin K. Along with that, you have to do for rapid reversal, you can either give fresh frozen plasma or you can give prothrombin complex concentrates. So ideal one is prothrombin complex concentrates, but this may not be available every time. So if this is not available, you can give fresh frozen plasma. The dose is 15 to 30 ml per kg. And the new one is, that is recombinant factor 7 is still under study. Thank you.